Hello, everyone, and welcome to the next installment in our series, Dr. Gilbert hosts. My name is Dr. Rebecca Gilbert, and I am the Chief Scientific Officer at American Parkinson Disease Association. Thank you so much for joining us today. Today, we'll be having a conversation with Dr. Joseph Friedman, who is an expert movement disorder physician, and he will share with us his pearls of wisdom on the best hacks, tricks, and medication tweaks to improve your movement and your day. First, Dr. Friedman will share with us some of his favorite hacks and tricks in a brief presentation. And then following that, we'll have a Q&A session where you will be able to ask your questions to Dr. Friedman directly, and I'll also share your own hacks and tricks with everyone listening. So I'd like to thank our sponsors, Accorda Therapeutics and Synovian, for generously sponsoring our program today. American Parkinson Disease Association, or APDA for short, is the largest grassroots network dedicated to fighting Parkinson's disease, and we work tirelessly to assist the more than 1 million people with Parkinson's disease in the United States live life to the fullest. Please visit our website at apdaparkinson.org to explore all that we have to offer. You can also contact APDA through our toll-free helpline, 1-800-223-2732, as well as via our social media outlets. And now I'd like to introduce my guest today, Dr. Joseph Friedman. Dr. Friedman received his MD from Columbia University College of Physicians and Surgeons and completed his neurology residency at the Neurologic Institute of New York. He's been a practicing movement disorder specialist at Butler Hospital in Rhode Island since 1982, and he's been working with APDA as the medical director of the Rhode Island chapter and as the medical director of the APDA Information and Referral Center at Butler Hospital since 1986. Dr. Friedman is professor of neurology at the Warren Alpert Medical School of Brown University and the chief of movement disorders at Butler Hospital. He's also written a free book on Parkinson's disease, and we will be sharing the website where you can access that book at the end of the presentation. I am very excited to be talking with Dr. Friedman today. Dr. Friedman, welcome, and thank you so much for joining us.
Well, thank you very, very much for inviting me. It's certainly an honor or a privilege to be able to share my thoughts about Parkinson's disease with a population of people who are directly affected by this disease, them and their families. And so I'm happy to be here. So I understand I'll be answering questions and addressing particular problems. I'd like to start off with the first one, which is about motivation for exercise. Exercise I consider extremely important in the management of Parkinson's disease, and I try to stress this to my patients at every visit, and I try at every visit to ask them whether they've been exercising. I consider exercise actually more important than medication. Exercise is an investment in your future. Exercise is what's going to be a determining factor, whether you're going to be able to walk well 5 years from now, 10 years, 15 years down the road. Whereas medication, while it is very important, is helpful really only for today or tomorrow maybe. But for the long run, exercise is the crucial thing. And I have an essay that I wrote, I think that's certainly distributed around here, which is that I encourage families of patients with Parkinson's to nag patients for only two reasons in general. One is anything related to safety, and the other is exercise. So nagging is good to encourage people to exercise. And I try to encourage them to exercise, at least 30 minutes a day, every day. And if they aim to do it every day, then they end up doing it maybe 5 days a week. One of the sort of anecdotes that I'd like to tell, which is true, which is that a long time ago, I read a study that was done in one of the Scandinavian countries where a family practitioner saw every one of his patients was encouraged to exercise. Every other patient, so 50% of the patients, he wrote a prescription saying that they should exercise 30 minutes a day, but all of them were told that. When they came back for a follow-up visit and he asked them whether they'd been exercising, he found that the people who got a written prescription actually exercised more than the people who did not get a written prescription. And so when I ask patients if they've been exercising and they repeatedly tell me no, then I write a prescription. I tell the family to put it on the refrigerator, and hopefully that's encouraging people to do more exercise than they have been doing. So exercise is crucial. You all know the motto is rest and rust, use it or lose it. I'm a very big believer in that. One of the things we all have experienced, those of us who are older like me, and perhaps many of you, is that when you lose some physical capability, it's say because you were sick, you suffered an injury, you hurt your back, that it's much harder to get back to where you were than it was when we were young. So you really don't want to lose any ground, and people who exercise more will do better. In Alzheimer's disease, which is obviously a different disease, people who exercise more have a more gradual decline with their loss of memory, and people who exercise more are less likely to develop memory problems than people who don't. The second problem that I'm going to address is the problem of nausea. And this is almost only a problem for people when they're first starting levodopa, sometimes with the dopamine agonist as well, but it's more common with levodopa. And so when I start patients on medication, I always tell them that most patients don't have any side effects from the medicine, but the two most common side effects are sleepiness and nausea, and that's what the carbidopa is for. I explained that the medication they take is a combination of carbidopa and levodopa, that levodopa is the active ingredient, and that carbidopa is there primarily to keep people from becoming nauseated. That when L-Dopa first came out and carbidopa hadn't been developed yet, my patients told me, I didn't have any patients in that era, but I took care of a fair number of patients when I first started who had been on levodopa alone before carbidopa, and they were nauseated most of the time. So there are a number of tricks that we can use. One of them, of course, is taking it with food. So I start people off by having them take it with food, and generally that's enough. Sometimes people have to start at a very low dose and increase it very gradually. So I usually start on a half a tablet 3 times a day with meals, breakfast, lunch, and supper, and then increase it after a week to a whole pill. If that's too fast an increase, then I'll have them take it a half a pill once a day with, say, lunch or supper, one of the larger meals. And after they've been on it a while and the nausea goes away, they can advance it to a half a pill twice a day with meals, then to 3 times a day, then they can go up to a whole pill with one of the meals and a half a pill with the other 2 meals, and gradually get on the drug. And this works for almost everybody, but of course not everybody. So we can add carbidopa. Carbidopa comes as a pill by itself. Even pharmacists sometimes aren't aware of it, but it is available. There's only one manufacturer of it, so it has a brand name as well as the trade name of carbidopa. And for reasons that I really have never understood, it costs far more than the combined drug carbidopa levodopa, and there's no reason to use carbidopa ever except for carbidopa levodopa when it's not enough to stop nausea. So carbidopa can be added 1 pill with each dose of the carbidopa levodopa. And then there are drugs that are used for reducing nausea. The most commonly used drugs for that purpose in the United States, unfortunately, are drugs that can make Parkinson's worse because they block dopamine receptors. However, one can use ondansetron, which is a drug that was developed primarily for people who were nauseated with chemotherapy, and that can be helpful. The problem with that is there's a large amount of constipation associated with it. Tribenzolamide is another anti-nausea drug that is very unlikely to produce any Parkinsonism. And then domperidone is a drug that one can get from Canada rather inexpensively that can be taken along with the carbidopa, levodopa, and it's probably the most widely used anti-nausea drug in the world, but is not available in the United States. It is legal to get it imported from Canada, and as I said, it's not expensive and can be used. The next problem to address is related to nausea, of course, which is weight loss. Most people with Parkinson's disease actually don't lose much weight, and there are certainly a fair number of people who gain weight because they're not able to exercise as much as they did before. But weight loss can be a problem, and the reasons for this are probably manifold. There's probably not one particular reason. Some people have difficulty with their swallowing, and so that prevents them from eating very much. A lot of people with Parkinson's, as you probably all know, have a decline in their sense of smell, and so many people will not have as much of an interest in food as they did before because they don't enjoy it as much. And I think that the slowness of eating sometimes reduces people's interest in food because they're often the last person at the table still eating when everybody else has finished. And over time, they start eating less and less in order to not slow down the other people. Certainly, if a person has long-term nausea, that will play a role as well, but that's much, much less common. So the first thing is to make the patient conscious of the weight loss, and also the primary care doctor has to be informed, because whenever people lose weight without specifically being on a weight loss diet, it needs to be evaluated by the primary care doctor because there are a lot of potential explanations, things like diabetes, things like overactive thyroid, sometimes malabsorption syndromes, but there are a variety of medical problems that are not related to Parkinson's that may cause weight loss. So it needs to be brought to the attention of the primary care doctor. Depression, for example, is a very common cause of weight loss. And as you all know, depression is a very common problem in Parkinson's disease. So there are a number of issues that need to be considered. And one needs to document that weight loss is in fact occurring. And the way I recommend checking that is to check your weight at least twice a week and do it in the morning before you eat breakfast or drink anything of substantial size so that you're getting a true weight, and look for any decline over a few weeks. If you are losing weight and there is no medical explanation, and you're not depressed, which would count as a medical explanation, then I generally recommend that if you don't have diabetes or lactose intolerance, that you should eat more ice cream. I think of the ice cream diet as an excellent way to gain weight, especially the high-fat ice creams. Ice cream, as you know, is easy to swallow. It's very much liked by Parkinson's disease patients. In fact, I did a study once looking at how much people with Parkinson's versus people who don't have Parkinson's but of the same age like ice cream, and people with Parkinson's tend to like ice cream significantly more and to eat more ice cream in general. And in fact, when I tell people that they ought to eat more ice cream, sometimes they tell me they can't eat any more ice cream because they're eating so much already. But I encourage people to eat ice cream because it has a lot of calories, it has calcium, it has protein from the milk, and that's one way of dealing with it. But it's very important to discuss this with your primary care doctor. If you have a gastroenterologist, it's another person you can discuss this with, and certainly occasionally a nutritionist may be needed. But even for people who have swallowing problems, ice cream in particular, because it's quite thick and easy to get down, is a natural product for them to use that they can eat quite safely. And in general, it's been my experience that even when people lose a substantial amount of weight, at some point they stop losing weight. But I do encourage them to gain weight if they can, and certainly to stop losing it, because I think after you lose a certain amount of weight, you start to become weaker and less able to exercise. The next topic is dizziness. And dizziness sounds easy, but it's actually a very complicated sort of issue, except when it isn't. The first issue when people complain about dizziness is, what do they mean by dizziness? Dizziness is, or the term dizzy means different things in different situations. So for example, when you were a little kid and you'd spin yourself around really fast and suddenly stop, the room would spin around and you would lose your balance and you had to put your feet far apart. That is called vertigo. And vertigo is one form of dizziness and almost always indicates a problem with your inner ear. On rare occasion, it may indicate a brain problem, but 99% of the time, it's an inner ear problem, and usually quite benign, although quite disabling when you have it. Another common problem people have that they call dizziness is that when they stand up, they become lightheaded. They feel like they're going to faint. And in fact, the reason for fainting is that your blood pressure drops. So that with Parkinson's disease, people often have what we call autonomic dysfunction, which is a problem with the nervous system control over things like blood pressure, sweating, your bowels, your bladder, things that are unconscious that you don't regularly control. And when normal people stand up, their blood pressure usually stays about the same. In young people, it actually goes up a little bit. But in Parkinson patients, frequently, their blood pressure will drop, often as the result of the Parkinson's, but also often as a result of medications that they take, certainly medications to treat high blood pressure, medications for prostate, and medications for the heart, often will contribute to a drop in blood pressure. While normal people feel lightheaded when their blood pressure isn't high enough, Parkinson patients sometimes will complain that their legs feel rubbery or they feel wobbly, and that can be treated. So if that's a consideration, you need to check your blood pressure sitting and then after standing for about 3 minutes, 2 to 3 minutes, and do this a few times during the day. Other issues that people, or other problems people talk about as being dizzy often is a funny feeling in the head. If any of you ever smoked cigarettes, the first time you smoke a cigarette, sometimes you feel this very funny feeling. You're not quite feeling faint. You're not feeling that the room is spinning, but there's some sense of something going on in your head that's dizzy. Many of my patients use the term dizzy to mean off balance, so that when they walk, they feel just that they're at risk of falling and have trouble staying staying upright. There are a number of ways of treating low blood pressure, which have to do with medication adjustments, increasing salt intake in particular, taking electrolyte beverages that are usually taken by athletes after they've sweated a lot, checking other medications to see whether they are contributing, sometimes wearing compression stockings to keep fluid from accumulating in the legs. On rare occasion, people may try using abdominal binders. This problem can be related, the lightheadedness problem can also be sometimes linked to a feeling of lightheadedness or fainting after one eats, which is called postprandial hypotension. The next problem I'm going to address is wearing off. So wearing off refers to the problem where the medication doesn't last long enough. So when people first start taking, say, Levodopa, they're usually taking it 3 times a day. They may take a dopamine agonist, the generic forms of which are also 3 times a day, sometimes a long-acting dopamine agonist, which may last all day. But oftentimes, especially since most people take Levodopa, the medicine stops working as much as it did initially. When people have mild Parkinson and first start the medicine, it can sometimes last as long as 6 hours or even longer. And over time, it works less and less. One way of dealing with that is to just increase the number of times you take the drug. So instead of taking it 3 times a day, you take it 4 times a day. But as you take it more and more, it takes over your life so that your life starts to become regulated by the clock. When is my next dose due? And you're always checking, and it's very inconvenient. And it can be life altering. And a lot of people, are too busy to remember. Some people just don't have good memories, and it's very difficult. There are 2 approaches to this problem besides simply increasing the frequency of the medicine. There are drugs that you can take that will prolong the duration of action of the levodopa. And there are formulations of levodopa that last longer than the regular carbidopa levodopa, or immediate release, as it's sometimes called. There's a long-acting preparation. There are 2 long-acting preparations. One is called continuous release, and the other is a capsule that's made up of little pellets, some of which are immediate release, some of which are long-acting. And then there are rescue medications. And the rescue medications are, one of which is an inhaled form of levodopa, and that starts to work generally within about 10 to 15 minutes. And because it's levodopa that people are already taking, its side effect profile is well known, and people can be sort of ready for whatever happens. The other one is a form of apomorphine, one of which is an injected form, and more recently a sublingual form has come out where you put it under the tongue, and it also starts to produce benefit within the next 10 minutes or so. The next problem that I will address is falling. So falling is something we all worry about all the time with Parkinson's patients because the risk of significant problems with falls is really quite obvious. More in women than in men because women's bones in the postmenopausal years tend to be much more brittle than with men. And the most important thing for that is probably physical therapy. It's important always to try to figure out what sorts of things cause falls. So one of them, of course, is orthostatic hypotension. That is when your blood pressure drops when you're standing. It puts you at greater risk for falling because you feel lightheaded. That will produce a sense of off balance. Or even without feeling lightheaded, your legs may feel rubbery and a person collapses. The other problems that contribute to falls are, of course, bad balance, which is often part of Parkinson's, and a decline in balance is something that we all experience as part of normal aging, but it's more serious in Parkinson's disease. And then there's freezing, where the feet freeze to the ground. And the person starts to move, but their feet don't go with them, and that will often lead to falls. And that's most commonly occurring when people are trying to turn, particularly turning in tight areas. So if they have a small kitchen, they're opening a heavy refrigerator door, their body turns, but their feet don't go with them, and that may lead to falls. The best treatment for these is, of course, first figuring out what causes it. If it's orthostatic hypotension, you address the hypotension. If it's freezing or balance, physical therapy is probably the best treatment for that. Adjusting medication sometimes can be helpful. There are people, for example, who fall, I think, because they have significant dyskinesias of their head. So if their head is bobbing back and forth as they're trying to walk, that's going to affect their inner ear, which provides their equilibrium, and will certainly increase their risk of falling. And then the treatment might be to reduce your medicines, which may sound somewhat paradoxical, but it really depends on trying to figure out what the cause of falling is. Again, physical therapy and exercise are crucial for most patients. The next problem is drooling. And I think drooling may be the single most embarrassing problem for patients, and certainly a problem that contributes to reluctance to socialize because people obviously are embarrassed when they drool. The reason people drool is not that they produce more saliva than other people. That's a misunderstanding. People with Parkinson's actually produce less saliva than other people their age, but they don't swallow as much. Just as they don't blink as much, they don't smile as much, they don't move their arms as much, they also don't swallow as much, so the saliva tends to pool in their mouth. And because their posture tends to be flexed, where they're bent over, their head is down a little bit, and the mouth is open, which is another aspect of Parkinson's disease, the saliva tends to come out. The first approach to dealing with that problem is to try sugar-free hard candy and sugar-free gum. Because even though gum and hard candy will increase the amount of saliva that's produced, it also increases the frequency of swallowing. So the more you swallow, the less likely you are to drool. And you need to have it sugar-free so you don't get cavities and lose your teeth. So that's one approach, which can be helpful for people with a mild problem. After that, there are medications that can be used. There are a number of medications that reduce saliva production. Paradoxically, they often cause patients to complain of dry mouth, but that's the way they work, by reducing saliva production. All of the drugs but one that reduce saliva production also contribute to constipation and reduce bladder contraction, so that people who have bladder control problems, particularly men with prostate enlargement, may have difficulty passing their urine. There's one drug, glycopyrrolate, that does not work on the brain. It does cause constipation and urinary problems, may cause blurred vision, but it doesn't affect memory. The other anticholinergic drugs, unfortunately, will often affect memory and thinking and contribute to the possibility of hallucinations. Botulinum toxin can be very helpful for drooling. It actually reduces saliva production, but when it works, patients find it to be very helpful. That requires some injections, but there are only 4 injections, and they're given only every 3 months or so. So it's not an onerous thing, and it's not very painful. The last problem that I will address is runny nose. So this is technically called rhinorrhea, and it's common in Parkinson's, so I don't know exactly how common, but I'd say probably at least 10%, probably more than that, will complain of runny nose. They produce a fluid that looks like water. It's quite clear, and it comes out throughout the day. It's often misdiagnosed as being an allergic response, but patients will point out that they have it all year round. And then the doctor will say, well, you're probably allergic to something in your house. But it's really probably part of Parkinson's disease, and it can be treated with a nasal spray called ipratropium, and is another example of the autonomic dysfunction that people with Parkinson have, just like the problem with lightheadedness when they stand up, or abnormalities of sweating, or problems with constipation. They're all part of the autonomic system. When I first discovered that people with Parkinson's have a runny nose, it was actually from my nurse practitioner, Carol Jakes, who worked with me for several years, and she told me about this, and I never paid much attention to it until I had this patient who had really very severe Parkinson's disease. He was in a wheelchair, and he told me that the only thing that really bothered him now was the runny nose, because for him, and for many people, although not all, that when they eat, the fluid production actually increases, so that his nose ran into his food, and this was terribly embarrassing to him, and he wouldn't want to eat around other people, but he couldn't prevent it. At that point, I started paying attention and discovered it was a very common problem. I asked Carol how to treat it, and she told me ipratropium nasal spray, and it works very well. And so I called up an ENT, an older ENT doctor who was a respected guy in my community. And I asked him about it because no one had ever published any paper identifying this. I'd never seen this written about. And he said, oh, yeah, we see it all the time. Everybody knows that. But of course, since nobody had written about it, the ENT doctors don't talk too much to neurologists, nobody knew about it. And most of them still don't know about it, I think, but it can be a bothersome problem. It's obviously not life-threatening, but actually, in general, very easy to treat. And I think that wraps up all of my questions, and I'll be happy to answer any questions from the audience. Thank you very much for giving me this opportunity.
Thank you very much for that excellent introduction and for giving us some great tidbits to take home with us. We have some additional questions for you that are coming from the audience. And please, if you're listening and you have a question, type it in now to the live chat, and we will try to address as many questions as we can. In addition, I'd like our audience to think about their favorite hack or trick that you use to improve your movement or your day. Please type that into the chat box as well throughout our discussion, and we'll try to share those as well as they come up. So let's begin. We have a question from Mary, which is about a very difficult non-motor symptom of Parkinson's that you didn't yet address, Dr. Friedman, and that is urination. Does Parkinson's increase the frequency of urination, and what is a good medication to help with that? And that's from Mary.
Yes. Parkinson's frequently causes what's called overactive bladder syndrome, in which patients have urge and frequency. That means that they have to go to the toilet more frequently more urgently than they did before. That is, once they get the urge to urinate, it's much harder to hold, and they have frequency. And the reason for that is that the bladder becomes what's called disinhibited, which means the bladder itself is a muscle. It's a smooth muscle. It's not like a skeletal muscle like your legs and arms have, but it is a muscle. And you know that when the doctor taps on your knee, for example, the muscle contracts and causes a jerk. So when your bladder fills up to a certain point, you start getting bladder contractions. It acts kind of like the reflex hammer, and the bladder starts to contract. And in Parkinson's disease, there are two problems that occur. One is it starts to contract when the amount of urine is much smaller than it should be to get a reaction. And the second is the contractions are much stronger. And then the third problem, of course, is now that you have to get to the toilet in a hurry, you have Parkinson's disease, so it takes you much longer to get there and to undo your clothes. So one of the ways of dealing with that, of course, is to try to reduce the amount of water that you drink, but you're always told that you need to drink more water because constipation is such a big problem when you get to be older and you have Parkinson's disease. One trick is to try to urinate on schedule so that you urinate every hour and a half or every hour, depending on your situation, whether you need to urinate or not, so that you never get a large amount of urine building up in your bladder, so you don't have the urgency to get there. There are a number of medications that can be useful for it. All of the medicines work to some degree. In men, it's more complicated because they often have prostate problems, and the prostate symptoms are pretty much the same as what you see with overactive bladder. And the drugs for bladder may make urination worse for a man with an enlarged prostate. But in general, there are a number of drugs that are very helpful for reducing urinary bladder contractions. The problem is most of them may have effects on the brain in terms of reducing memory and thinking, and all of them basically will contribute to constipation and dry mouth. So miragrabon and ipratropium and trospium, I'm getting the words confused. Trospium and miragrabon are two of the newer drugs that are good for reducing bladder overactivity, which do not affect the brain, so that they are safe for people who are having memory or problems with hallucinations. But they do cause constipation, which can be a problem.
Okay, great. Thank you so much for that information. We have a great question from Mike from California, which is, can you discuss frozen shoulder as part of Parkinson's disease? Is it a separate entity? Is it part of Parkinson's? What can be done about that?
Yeah, that's interesting. So frozen shoulder was described actually in the late 1980s as being a symptom that predates Parkinson's disease. There was a study that was done out of Canada, um, and I've certainly seen it a fair number of times myself, where patients develop a problem with their shoulder. They're seen by an orthopedist who diagnoses frozen shoulder, and then over the next 2 or 3 years, it's recognized that they have Parkinson's disease, with the side that the frozen shoulder was on being the first side that's affected and the more affected side. Interestingly enough, we don't see that so much in people once they've developed all of the signs of Parkinson's. Right at the earliest stages, what happens is it's also called capsulitis. I'm sorry, where there's an inflammation in the capsule around the shoulder that causes the shoulder to move less and the arm to swing less and less, and it's painful. And it's assumed, at least I assume, that it's the Parkinson's disease that leads to the capsule being inflamed. Certainly the capsule doesn't lead to Parkinson's disease. So I think it's a matter of that the arm stops swinging, and by the time they get to the orthopedist, everybody thinks, well, that's because it's a shoulder problem. But really it started because the arm wasn't swinging as a result of the Parkinson's disease. And then it became painful. And then after a period of time, maybe a tremor began, or the other side started to become affected, or the walking changed, and the capsulitis was recognized as just being a preliminary symptom of Parkinson's disease.
Yeah.
So somebody who presents with a frozen shoulder and no particular explanation, certainly they should consider the possibility that it's Parkinson's disease. But it's now a well-described and well-recognized syndrome. Fairly uncommon, but common enough that neurologists will see it.
Yeah, thank you so much for that question from Mike, and for that answer. Of course, hindsight is 2020, but yeah, we all see patients like this who had a whole workup for frozen shoulder, maybe even got surgery, and it turns out it may have all had been part of the Parkinson's. We have a great question from Deb on a topic that we haven't discussed yet that needs to be addressed, which is, could you discuss treating constipation?
Yeah, so constipation can be a very big problem in Parkinson's disease. And I encourage patients to try to have a bowel movement at least every 3 days. Obviously, every day would be better, but at least every 3 days. And the concern is that the longer you're constipated, the harder it is to pass your stool, because the main function of your large intestine is to remove liquid from the stool. So when the stool is very hard, it's the result of the water being removed, and that makes it harder to push out. And sometimes people get into the very unfortunate situation where they have to be disimpacted, it means somebody sticking their finger into you and pulling it out, which is painful and unpleasant. So you want to avoid that. So the first thing I do is to recommend a high fiber diet to everybody. So increasing your fiber should increase your bowel movements. That may not be adequate for somebody with Parkinson's disease. And then I recommend increasing their fiber intake. And one can do that by taking products like psyllium or polyethylene glycol. So that's Miralax or Metamucil and substances like that. And one thing to keep in mind with those is that they're not absorbed by the body, so they don't have any systemic side effects, and you don't become addicted to them. They are basically like eating tiny sponges. They allow your stool to expand and get softer, and so they're larger and easier to expel. And there's no limit on how much you can take. The only side effects people run into if they take too much is that they might become gassy, or they might have somewhat loose stools. and then you can titrate by adjusting it up or down. When you look at the package of these supplements, which are all over the counter, they give you directions on how to use it, but you can take more. You don't have to take Miralax once a day. You can take it twice a day. You can take a larger amount than they recommend. And I recommend increasing as needed. If they haven't had a bowel movement by the third day, then I recommend taking a laxative or an enema. The difficulty with laxatives is that people can become dependent on that if they end up using it all the time. But probably that's better than going a week or sometimes 2 weeks without having a bowel movement. That's potentially quite dangerous for the patient and leads to further problems down the line.
Such a common problem for people with Parkinson's. So thanks for running through all those options. We have a clarification question from Michael. On your slide about medications not lasting long enough, the last item that you didn't address was DBS and some kind of infusion. Could you talk a little bit about that infusion right now?
So thank you. So there are two surgical approaches that are approved now for wearing off. One is deep brain stimulation surgery, which patients often think is sort of cutting edge science fiction sort of thing, but really has been around now for about 25 years or so, and is a standard approach to treating Parkinson's, and it's paid for by all of the insurance companies. Usually we use that for people who are not just having wearing off, they're having wearing off in association with dyskinesias. So the dyskinesias are those fidgety involuntary movements that you've probably all seen with Michael J. Fox. And so it's very good at reducing the dyskinesias or even eliminating them while prolonging the on time. For people who just have wearing off without the dyskinesias, it would be rare that anybody would recommend deep brain stimulation surgery. But certainly with the fluctuations where you're over-medicated and then under-medicated, DBS is a extremely helpful intervention. The infusion pump is a way of delivering a gel form of carbidopa levodopa directly into the small intestines. So it's considered a surgical option because you have to put in a very tiny catheter, which is basically like a feeding tube. The tube doesn't go directly, it goes into the stomach, but through the stomach and out the other end into the small intestine. And the pump infuses a continuous amount of levodopa into this portion of the small intestine where the drug is absorbed. So it's absorbed very quickly and gets into the bloodstream and provides a stable level of drug in the bloodstream, unlike when you take your pills, where the level of the drug in your blood goes up and down. With the continuous infusion, it stays at a stable level. The results of that look on paper to be about the same as with deep brain stimulation surgery. And the surgery, of course, is just putting in a feeding tube type device versus deep brain stimulation where they put in, very tiny needle electrodes into your brain and a stimulator type of device under your skin.
Okay, great. Thanks for those clarifications. We have a question from Joanne. I was told to have no protein 1 hour before and 1 hour after taking my carbidopa levodopa. So I fast during these times. Is this what you recommend?
Generally not. And the reason for that is that for most people, in my experience at least, taking protein doesn't interfere enough to make it important to adjust your diet around it. The observation was made a long time ago that certain amino acids, which are breakdown products of protein, can interfere with levodopa. They interfere by blocking its absorption into the blood, and they interfere blocking the absorption from the blood into the brain. So theoretically, amino acids can block levodopa and make it much less effective. What I tell patients is that they can do an experiment and see whether that actually applies to them. So they can see whether their response to their levodopa, and the protein only interferes with levodopa, not any of the other drugs that we use in Parkinson's disease. And it has no direct on Parkinson's disease itself. So it's a drug interaction of amino acids with levodopa. And I tell them to do an experiment that they can go a day without taking any protein. And you can have a very nice diet without protein, at least a nice diet for me, where you can eat baked goods, pasta, fruits, vegetables, and just avoid meat and animal products, and see whether it makes a difference in how you do versus, say, having a hamburger or a tuna fish sandwich, or a lot of dairy products or eggs, things that are rich in protein. Does it make a difference? If it makes a difference, then you need to do what your doctor suggested. If you don't see a difference, then it doesn't. It's really a matter of what you experience is the answer as to whether it's a problem or not a problem.
Okay, great. That's a great clarification. So many people ask that question, and if you need to avoid protein, you do, and if you don't, you don't. So thanks for that. I want to provide a clarification for Donna, who asks, have the alternate forms of levodopa, inhaled and under the tongue, been approved? So just to clarify, the inhaled levodopa, both have been approved. One is inhaled levodopa, but the under the tongue is not levodopa. It's apomorphine, and that also has been approved. So both of those as needed medications that Dr. Friedman mentioned are approved medications. So just wanted to clarify that for Donna. We have a question from RB, which is, how do you determine if this is a doozy, how do you determine if someone has Parkinson's or MSA? My wife was originally diagnosed with Parkinson's, but now the doctor is saying that she has MSA. Can you address that for our audience?
So there are a number of neurological disorders that share many of the features of Parkinson's disease. And as you know, with Parkinson's disease, problems don't all develop at the same time. So some people will start with a tremor and have virtually nothing else. Some people will start with slowness, and then a year later they start developing a tremor. So it's a process. The disease is a process, and it changes over time. And there are a number of disorders that share many of the Parkinson features that turn out not to be Parkinson's disease. So multiple system atrophy is one of them. Progressive supranuclear palsy is another. And then there are a whole host of other disorders with names that most people, including doctors, are unfamiliar with that can look exactly like Parkinson's early on. The usual distinguishing features are that in multiple system atrophy, it's usually quite symmetric, whereas Parkinson's disease is usually asymmetric. Now, keep in mind, I'm saying usually, okay? It's not 100% of the time. So doctors who see a lot of Parkinson's recognize that it's not 100% of the time. And multiple system atrophy tends not to respond to levodopa, and Parkinson's disease should respond to levodopa. Now, there's often a placebo response so that you can't always be sure. And some multiple system atrophy patients may respond, but most don't. So when you use levodopa in a patient where the disease is symmetric, and typically with multiple system atrophy, they don't have tremor, whereas about 80% of people with Parkinson's do have tremor. And so those are the major features for most patients. And early on, especially in a Parkinson's patient who doesn't have tremor, you really can't tell them apart. To be sure or relatively sure about the diagnosis of multiple system atrophy, they typically have significant autonomic dysfunction. Usually, they have very severe drops in their blood pressure when they stand up. And it often becomes so severe that they even have trouble sitting up because they may faint because of that, but have a lot more trouble standing up than people with Parkinson's. Because as I mentioned in the talk earlier, people with Parkinson's often have this problem as well. And where you say that one is so severe it's not Parkinson's, and where it isn't, as a matter of judgment, you can't always be right. Finally, there are two types of multiple system atrophy. One is called the cerebellar type, where people have a problem with clumsiness that we call ataxia, where they may sound like they're drunk, or in addition to have the walking problems of Parkinson's, may have their feet far apart and walk as if they were drunk in addition to having Parkinson's. And that never occurs in Parkinson's. So when that occurs, it's very easy to make the diagnosis, or at least the distinction. The other form of multiple system atrophy is the Parkinson type, but they often have very brisk reflexes, brisker than you would see in Parkinson's disease. But we can't always tell them apart, and certainly early on, we can't really tell them apart. And when you think about a test called the DAT scan, the dopamine transporter scan that you may have heard of, which is a test that tells us whether or not there is a reduction in dopamine. The dopamine is reduced in multiple system atrophy like it is in Parkinson's disease, so that we can't use that test to distinguish them either. So it's not uncommon to initially diagnose somebody as having Parkinson's disease. And then with time, as the illness progresses and new things develop, we change the diagnosis.
Yeah, so thank you so much, RB, for that question. It's one that we get a lot and that we have to navigate along with our patients. We have only time for one last question, amazingly. This hour has flown by, and this is from Joan. Does acupuncture help with symptoms of Parkinson's?
As far as I'm aware, there are no double-blind placebo-controlled trials. That's our gold standards for assessing something working or not working. I get asked about acupuncture by my patients a fair amount of time. I mean, not everybody. And I tell them that we don't know if it works or not, but that it's safe. That is, assuming your acupuncture person is licensed. The acupuncture is safe. I believe that the acupuncture practitioners may focus their treatments, that is what stimulation points they use, depending on the symptoms they want to treat. And I tell people that they can try it, and if they think it works, that's fine, and continue doing it. And if it doesn't work, well, at least they will have tried. A lot of people try it because their neighbor, their friends, their children, whatever, think that it's going to supply some tremendous help, and it may, but and obviously you don't know till you try, and won't cause any harm. I will acquiesce. I never recommend it because we don't have data that it really works. But if a person is interested in trying acupuncture, I don't discourage it either.
Fair enough. Thank you so much for that question and that answer. On that note, we unfortunately have to wrap up and leave many questions unanswered. But I want to thank Dr. Friedman for a wonderful presentation. I want to thank you for all your extremely valuable information, and to everyone listening for providing the questions that informed our conversation. So thank you so much. If you know someone who missed today's program, if you joined late, if you'd like to watch it again, if you missed anything, then you want to go back to the slides, this recording will be available later today on our YouTube channel. And when you're on our YouTube channel, don't forget to subscribe to APDA's YouTube channel, because you'll be able to get notified about any of our new videos and live broadcasts. Again, I would like to thank our sponsors, Accorda Therapeutics and Synovian, for generously supporting today's program. I also want to point out that Dr. Friedman's free Parkinson's disease book is available at this URL, which is tinyurl.com/freepdguide. So check that out for many more tips, as well as videos and a lot of information about Parkinson's from Dr. Friedman. For additional information and resources, please visit our website at apdaparkinson.org. I would like to notify you about our next episode of Dr. Gilbert Hosts, which will be held on Friday, May 7th at noon Eastern Standard Time. I will be hosting Dr. Walter Koroshetz, who is the director of the National Institute for Neurologic Diseases and Stroke, also known as NINDS, which is a division of the NIH. And we will be having a conversation about PD research at the NIH. So that should be really interesting. Please register for this session. You can do that right now. And you can also register for many of our other virtual programs using our virtual calendar. You go to apdaparkinson.org/events, scroll to May 7th, and you can register for our next Dr. Gilbert Hosts with Dr. Koroshetz. Now, if you enjoyed today's webinar, we hope you'll consider supporting APDA with a donation, because with your help, APDA can deliver more programs and services like this one. I want to thank everyone again for joining us today, and we hope to see you soon on another APDA program. Have a wonderful afternoon.